Hello, Claire. It's good to see you again. Always nice to talk to you. And one of the things that I'd like to perhaps have a quick chat with you about over the next 10 minutes is just to get your sense of the development of the Welsh Falls framework for ambulance services, and about how that relates to the principles of spread and scale that we've been discussing over the last few months between us and within Horizons. So tell me a little bit about where the Falls framework came from in Wales, and why you saw the need to develop that.
Okay, so it's great to be able to talk about the framework today, and linking it in with the principles of spread. I mean, we've been working on the Falls framework in Wales now for a couple of years, and it started really with the fact that we knew we had a real patient safety and patient experience concerns with people who were falling, and people who were waiting quite a long time for us to get to them because of the general demand in the system, and because of the fact that particularly people who fall and perhaps may not necessarily have injured themselves would not necessarily be a very high priority when you think about all of the other priorities in terms of somebody having a cardiac arrest or a stroke, or having a myocardial infarction. Obviously what happens within the ambulance services, lots of calls come in, they get prioritised in terms of their acuity, and what we were finding was that we had a real issue with people who had fallen, who may or may not have been injured, but particularly those people who weren't injured were coming to unintended harm because we were taking a long time to get to them, because other priorities were coming in the meantime after their call. So we knew from our complaints and from our concerns and from our patient experience stories and what the public were telling us that we really had a bit of a patient safety and a patient experience problem with falls, and we needed to do something differently. So to be honest, we started off trying to have a falls improvement plan, and we soon realised that was just not, it wasn't going to be able to be very appropriate for what we were trying to achieve. And a lot of that was because what we were trying to achieve was really complex. So this wasn't a very simple problem we needed to try and find a one-size-fits-all solution for. It was very, very complex. There was, multiple factors influencing that, and we needed to come up with something that would have some flexibility in it. So after, quite a long time of being able to do a lot of thinking and sense making, we eventually came up with a very holistic framework for falls, which recognised our role in prevention and supporting the community's resilience and avoiding further harm. But predominantly then, those were part of the factors of the framework, but predominantly a real focus on how we assess falls, and importantly, how we respond to them.
Okay. And what would you say were the main elements of the Falls framework in Wales that made it a success? Was it,
Okay, so I think, I think in terms of where we've got to now, I think in the early days when we were trying to describe the Falls framework and trying to make sense of it ourselves as an organisation, and then talking to other people about it, what I found in the early days of that work as we were trying to articulate it and describe it, it was very visual. And it was very simple. And so there's a real irony in here, in that we had a very visual, very simple framework and model about something that's really complex and really difficult, and as I would describe it, a wicked issue. And that simplicity and that clarity of what we were trying to achieve, when we were talking to people across the system, it really helped the conversations, and cutting through the complexity of it enabled some really deep and meaningful conversations around what we were trying to achieve.
Brilliant. And in terms of some of the achievements that have subsequently followed from, I guess, having that falls framework across Wales, can you give me, I don't know, just one example of an improvement that subsequently occurred?
Okay, so one of the things that we did was we really, really focused on where our greatest priority was. And we recognized that where we were having the sort of almost a disproportionate amount of harm to patients was in the particular category of people who'd fallen but weren't injured.
Mhm.
And the most important thing for those people was that we got to them in a timely manner. And because of the low acuity of that call, because they weren't injured, actually we weren't doing that. They were continually slipping down our stack of priorities. So we partnered with St John Cymru in Wales to be able to develop a falls assistant response. The falls assistant just describes the type of response that we need to respond to people with that level of acuity. And that's about getting to somebody quickly. It's about being able to assess the situation. It's about being able to pick them up off the floor in a timely manner so that they don't come to harm. Because people who have fallen but are not injured, particularly in our elderly population or our frail population, it's not the fall that causes them harm because they haven't got injured from that. What causes them harm is laying on the floor for a long period of time. So we described what that service looked like, and we had a whole protocol around that service and governance around it so that the clinical decision making was made by our clinicians on our clinical desk in our contact centre, but the service to get to the person and provide a face-to-face service and get them up off the floor, we recognised didn't need to be done by a clinician. So that was really applying some prudent healthcare principles to that approach. So once we understood the type of service we needed to have in place, we then realised that we could do that in a number of ways. So we do provide that ourselves with our community first responders. We can have conversations with lots of different other partners to be able to provide that in different parts of Wales. But along the South Wales corridor, we developed a partnership with St John Cymru where they provide a falls assistant response, and they work in partnership with our teams then to have a clinical assessment over the phone. And that is actually now being spread across the whole of Wales, and our ambition for January, the end of January 2020, is that we will have a falls assistant vehicle in all 7 health boards.
Gosh, such great progress from developing the falls framework. If I can just move the conversation on a little bit then, Claire, we've spoken in recent weeks about the principles around the spread and scale of innovation and improvement, and I know you've taken a keen interest in that. I guess just give me a sense in terms of those 7 principles, which ones you particularly see appropriate for your development of the falls framework in Wales.
Okay, so I've already mentioned complexity, and I would say that that's probably the one that jumps out at me the most, because of really how difficult it was in the early days trying to make sense of this, and it was very complex, and it still is. We're certainly not in a place where the falls framework and falls response model is completely spread across the whole of Wales, and in some areas not maybe completely understood. So it is a continual, ongoing process. I think there's something for me around the individual in this. So when we were, having some of our darkest moments when we were trying to make sense of it, and at times those conversations were very, very difficult, I think bringing it back to the patient and bringing it back to the patient experience of, what it is like for people, particularly elderly or frail people, to be in a situation where they are laying on a floor for a long period of time, waiting for a response to get to them. I think that really focuses you. It focuses you about being able to really focus on what are we trying to achieve for that individual. I definitely think there's something for me about the value of what we are trying to do. So, why is this work so important? And it goes back to the individual. It's about being able to respond to people in a timely manner. It's about giving them effective care and safe care, and avoiding people coming to further harm. And that's important for the individual, but it's also really important for the whole value across the system. So if you've got somebody who's fallen over, they weren't injured, and actually we got to them in a timely manner, picked them up off the floor, done an assessment on them, made them a cup of tea, checked they're okay. Our intervention early in that can prevent further things happen. If we get to people hours after they've fallen over, and actually when we get to them, we're faced with a very difficult, different clinical picture. Somebody who's now becoming quite dehydrated, they've laid on the floor for long periods of time, they might be really cold. And actually in our older, frailer population, that then means that what we've got is a situation where actually we do need to take somebody to hospital because they've come to harm, because we didn't get to them quickly enough. And not only is that an impact for us as a service, but it's an impact for the whole system, isn't it? It's potentially an unnecessary admission to hospital. And the most important person in that is the person who's being transferred to hospital, because we don't want anybody to go to hospital who doesn't need to go, particularly if they're elderly or frail, because we all know that that's not good for people. People will, become less mobile, they will decondition. So I think that value bit in terms of the whole system is not just valuable for the individual, and clearly that's the most important thing, but it's valuable for the whole system. And I guess another angle to that is if you've got an emergency ambulance that then is required to attend to somebody who's come to harm because they've been waiting for a response for us for a long time, that emergency ambulance is then responding to something that shouldn't have needed an emergency ambulance if we got there in a more timely manner. And that means that that emergency ambulance is not free to respond to a cardiac arrest or, somebody who's having a stroke. So I think when you start to talk about value and you look at the absolute impact of we're actually getting to somebody in a timely manner, how that affects value across the whole system, that's really quite powerful and impactful in terms of what you're trying to achieve.
Great. So the concept of value is really central in terms of principle for you, in terms of how you scale.
Yeah, I think so.
Yeah. And I've also heard there as well, I think, elements about thinking about the individual, but also obviously the complexity of what you were dealing with as well.
Yeah, and that, continual learning, so, when we started introducing these different ways of working, we were doing them on the basis of, trialing them and testing them and, using your classic PDSA cycle to stop and think, what are we doing next? But actually that's continued. That's never stopped, and I don't think it ever will, actually, because it's such a complex issue, and it's not just about the fall, it's about much more about that in terms of the health and social care determinants of health, that actually, I don't think we're ever going to get to a point where there is no learning in it. It is just continually evolving.
Okay, thanks, Claire. Again, one of the other things that we've been discussing with yourselves over the last couple of months has been this sort of concept of I'm going to call it sort of program management vis-a-vis convening a system. And I just wondered if you had any thoughts around that and about how you think that those relate to the Falls framework in Wales.
Yeah, well, I think I've said this to you before, Ian. I absolutely wish that I had had, your slide that was shared at the expo in relation to sort of the project management and the system convening, and how they differ, but how you need both of them. And yeah, I think if I'd been shown that slide 2 years ago when we were trying to make sense of all of this, it would have been very helpful. Because I think, when we, within the NHS and within the way that we work, I think we're very, very comfortable with project management. We've got an aim, we've got some objectives, we look about how we're going to measure those. And we've got a framework for it. We've got our risks. What are our risks around doing this? And it's kind of like a governance structure that we probably feel very, very comfortable with. And what I found with the Falls framework was that it just evolved, and it evolved through various different people coming together to talk about it. It is continuing to evolve. When you've got multiple partners that you need to work with, you have to be able to have that, unconstricted sort of allowance for emergence. And I think that that's when you haven't done that before, when you're going through it, and I was sort of going through this, not kind of thinking about the theoretical sort of insights into it, I suppose. Sometimes that felt really uncomfortable, because we were having to try things and look at doing things in a different way, and that involved taking some risks. Mm-hmm. And we're not comfortable with that. It's not what we're used to, and we didn't want to introduce risk either. And yes, I'd have loved to have had that slide about 2 years ago to have thought, oh, it's okay for me to feel uncomfortable. This is okay. And actually, what I found was that within the group of us that were all working together, there was various different appetites for moving away from project management type style to more emergent styles, and that requires I think that requires a really emotionally intelligent leadership, because people do feel uncomfortable with that.
Yeah.
And you have to be able to make sure that you can take people with you on that journey. And I'll be really honest, there were many times in the beginning of the development of the framework and the model that I often felt uncomfortable, because it was throwing me out of my comfort zone of that whole put in risk and being able to think about the risks we were taking. And yeah, there's it's very and it continues. There's many conversations on a weekly basis where I find myself feeling uncomfortable about that.
I was going to ask you that actually in terms of the sort of final question, Claire. I mean, where next for the Falls framework then in Wales? Where do you see it going next?
Okay, so I think for us as an organisation, it's now become the way we do things around Falls. Okay. So we're no longer seeing it as something that we're trying to steer. It's now about, we have a model, we have a framework. How do we continue to implement it, and how do we continue to spread that throughout Wales? Because obviously we've got some areas of Wales where we have implemented the level 1 and the level 2 of the model. And in other parts of Wales, we're just starting to implement level 1. And also, you've got to allow for the flexibility of local variation. And what we may find is that we'll have different partners in different parts of Wales to be able to provide the various different responses. So I think where we're at now, it's people understand it. People, understand what level 1 is and level 2. It was great for me a little while ago to be in an operational area one of our clinical contact centres, and people were just talking about level 1 and level 2 falls response. And I wanted to kind of do a little bit of a fist pump, because I was like, oh my God, people are really getting it. I mean, our focus now, because we've implemented level 1 across all of the 7 health board areas, that's not to say that we don't need to continue to scale it up, because although we have 7 health board areas, some of those are really big geographically. So we may find that, level 1 is operating just in one part of their service, and then we'll have to look at how we scale that up. But our focus is going to be shifting now into 2020 onto level 2. And that is, going to be a real opportunity and a challenge for us, because with level 2, we absolutely have to do that in partnership with our health board colleagues. It's not something that we can implement on our own. And then the other thing that we really, really want to be able to focus on is how we are really contributing to the prevention part of the framework and the supporting community resilience. So we're part of the National Falls Task Force in Wales, which is has a very strong focus on prevention, and it's about using those various different forums to be able to continually engage across the system. And we need to evaluate continuously, I suppose, how that's operating. So one of the things we've done just about a couple of months ago is that we looked at implementing a dedicated falls desk within our clinical contact centre. We've done an evaluation on that, and we now need to present that to our executive team in terms of how we would scale that up, because obviously when you do one thing, there's a consequence somewhere else, and there was a huge amount of learning for that, actually. So yeah, that's where we are at the moment.
That's fantastic. So all that remains for me to say is to say thank you again, Claire, for all the time that you've given to us in terms of helping us, I guess, assimilate our own thoughts around sort of scale and spread by using your own example there within Wales with the Falls framework. So thank you very much, and hope to see you again soon. Thank you.
Yeah, it's my pleasure. Thank you, Ian.
Thank you.